Good afternoon, everyone, and welcome to the Doctor's Inn. My name is Ed Miller. I work with David Griffith. I'm the social engagement manager here at the Elder Initiative. And I'm joined here with Dr. Lily Flink. And our topic today is dementia and cognitive health. A big shout out and thank you to Jefferson Department of Family and Community Medicine. As a reminder, just so you know, you can put questions in the chat, and Dr. Flink will field those questions at the end. And you can also use the Q&A section, which allows you to make a comment or ask a question anonymously. So the chat or the question and answer fields are available for you to use during the presentation. Make sure I'm not missing anything. Yeah, so Doctor, are you ready to get started?
I'm ready. Can you hear me okay?
Yes, thank you for being here.
My pleasure. Thanks for having me. I'm Lily. I am doing my fellowship in geriatrics at Jefferson right now. I'm trained in family medicine. And we'll be talking a bit about dementia today. Please use the chat or the Q&A or whatever. I hope this will be interactive, and I hope that we can get some of your questions answered. Though I will say there's a lot that we still don't understand about dementia, and this is not going to be all encompassing. I've tried to cover a lot of the main areas, but please ask away if you have questions, and hopefully I can see them while we go. If not, I will make sure we get to them at the end. See if I can get my slides to move. Okay. So talking a little bit about why this is so relevant. I think most of us know that the geriatric or older adult population is growing in the US, but just some numbers to kind of give a little bit of context here. So right now there are about 56 million older adults, which I define as over 65, though we can get into more gradation there. And that number is expected to double by 2060. So adults over 65 right now are 16% of the US population. That percentage will jump to about 23%. So we are looking at an expanding older population in the United States. Right now, in terms of adults in the US with dementia, that number is estimated to be about 5.8 million. And again, by 2060, that number will more than double. So about 14 million adults with dementia. And then kind of relevant for us as providers of care, and also for patients and their loved ones, the costs are growing exponentially as well. And the numbers, as we talked about here. I want to take a little bit of time to talk about kind of normal parts of aging that I think happen very commonly and give people pause and sometimes worry, and kind of hopefully you'll walk away from this talk with a very strong understanding of what is normal and what is atypical, what is not dementia and not cause for concern. So simple forgetfulness, things like needing more time to recall a word, having something on the tip of your tongue, but losing that word. I know it happens to me. I know it happens to probably all of us. These are things that are mild memory decline, but they don't interfere with our functioning. We are still able to learn new things. It could take longer, but you're still able to learn new skills, new tasks, new facts. And leaning heavily on lists, notes, calendars, these are all normal things that we may need more of as we age. But again, functioning on a day-to-day and executive functioning like planning is something that remains intact. These are not part of dementia or cognitive impairment, which we'll kind of tease out a little bit later. Some problems that may show up are things like forgetting recent events, forgetting appointments, and forgetting conversations that you've had, forgetting how to do things that you've done before or that you've learned before, and this is probably a sign of advanced dementia, a real difficulty learning new things or new skills, repeating phrases, questions, and stories in the same conversation. One big functional piece that we pick up on often is trouble making certain complex decisions or handling finances, and then ultimately losing awareness that you're forgetting. So often for people who notice they're forgetting, that's actually a sign of strength for us. And these things all interfere with day-to-day life. This is not typical aging. This is not a normal, inevitable part of aging necessarily. And I also just want to acknowledge there are many causes of changes in memory or forgetfulness. So this talk on dementia also does not explain every kind of memory change or memory loss, and that can be due to medication side effects. I didn't really talk about this more in this talk, but especially talking to your doctor or your healthcare team about the medications that you're on. As you get older, they get processed differently, and those side effects can impair thinking, focusing, concentration, energy, and are important to always be mindful of and weighing as you get older. And then other health problems can really mimic memory loss and can cause memory changes. So mood issues like anxiety and depression can certainly cause memory changes. And we'll talk about that a bit more. Problems with sleep. I know if I don't sleep well, I feel like I'm in a fog the next day. If that's something that's ongoing, that can certainly impact your memory and your ability to think clearly. Heart disease, infections, head injuries, having thyroid abnormalities, just being dehydrated or not having a balanced nutritional intake, having vitamin deficiencies. The thing that I don't want people to jump to if you're forgetful at times, but is definitely on our radar, is like a brain tumor or cancer. So there's so many things that cause memory changes. We'll talk about, just kind of zoom in on dementia or major neurocognitive changes, as they're now called. So I think it's really helpful to outline some definitions so we know what we are talking about and what we aren't talking about, and what falls under dementia and what doesn't. And the technical definition of dementia that I want to use for today is from the Alzheimer's Association, plug for a very, very helpful and useful website with tons of resources for patients, families, and providers, is that dementia is a general term for a loss of memory, language, problem solving, and other thinking abilities that are severe enough or so severe that they interfere with daily life. And that is a key piece here. Things that interfere with your day-to-day ability to function or maintain independence. So said otherwise, this is a significant decline that we see in areas of cognitive function, and that results in what we call functional decline, or kind of your day-to-day life. That's a term we use a lot in geriatrics. And again, hopefully you know this by now, but I think we learn things through repetition. This is not an inherent aspect of aging. This is different from your typical or common lapse of forgetting something, a one-off, let's say. And this is a progressive and a disabling condition. It's also a syndrome. It's not one single or specific illness. Dementia encapsulates many subtypes, which we'll talk about in a little bit. One other definition that I hear thrown around often and that we use with patients to distinguish from dementia is what we call mild cognitive impairment. So we do similar workup that we would do, that I'll talk about for memory evaluations. And this is something that we're noticing changes in thinking or memory, but it does not interfere with daily functioning. People are able to maintain independence, but we are seeing some maybe changes on their memory testing. And about 10% of these cases progress to dementia. Not all mild cognitive impairment cases go on to become full-blown dementia. I'm not really going to focus on this more today because I feel like there's a lot to talk about with dementia, but I just want to be clear that this is something that is distinct from dementia, a dementia diagnosis. These are just some of the risk factors for dementia, and many of these things actually are modifiable or in our control, which is something that gives me hope. Some of these things like family history or genetics, obviously we cannot control as much. Age also, like this does occur more as people get older. But things like diabetes, high cholesterol, high blood pressure, smoking, the sleep apnea, these are all conditions that are modifiable and controllable. And I think the underlying piece of dementia that is important to take away is that having good health and prioritizing health are already so much that you can do for your cognitive health as you get older. And there are many protective factors. We'll talk about some of these later on in terms of treating dementia, but in terms of preventing, there is good evidence to support certain diets that can help stave off dementia, and a lot of evidence to show how important physical activity is in maintaining cognitive function and brain activity. So reading, staying active, staying social, engaging in community, these are all things that we know are protective against dementia. I see the question about low education. That is, there is some association, and it's not causational, but there's association between poor education, like not finishing as much school or poor quality of education, and developing dementia. And I think some of this has to do with thinking about the brain as a muscle, and kind of like, if you don't use it or use certain parts of it, you lose those parts. And it's similar with socialization and community, but I think just thinking about engaging your brain, and having a low level of education is something that's a part of that whole equation. In terms of reading level, we know that people who are reading frequently and in older age are able to maintain sort of brain or cognitive health. So that's kind of what I mean by that. So a brief word on screening for dementia. And what I mean by screening is that we think about this as very different from diagnosing dementia. And that's why it's a little bit controversial. So when we think about screening, the first things that come to mind for me are screening like cancer screening. Those are things that we do for every person over a certain age. So what I mean by screening for dementia is that it is not actually currently recommended by the U.S. Preventive Services Task Force to test all patients over a certain age for dementia. The problem with that is that many, and there's kind of a big range in terms of sources, is that many patients who have dementia may go unnoticed or undiagnosed in a primary care setting. So I think what's helpful is that to take away from this is that if you notice something about yourself or a loved one, it's important to bring it up to a provider, because there are tests we can do and there is a workup we can do. And screening is different than a workup and diagnosis. So someone who's healthy and 65 and has no concerns is not going to undergo a test for dementia. It's not recommended. And that's definitely recommended for other things too. We don't screen universally for all conditions. We screen it based on a suspicion or a concern. That being said, if you're on Medicare, you probably have gotten a Medicare annual wellness visit from your provider, or like your yearly check-in. And there is a kind of provider gestalt or observation screening that provider will do just to see if they have concerns or not. And it's just to draw attention to, but there used to be kind of routine brief screening for dementia that has been removed from the Medicare annual wellness visit. As a sidebar, I'm doing a research project on this. I could talk about that for a very long time, and it gets a little bit nuanced. So if there are questions about that, we can talk more about it at the end, but hopefully this doesn't cause more confusion, because I do want to focus on what it actually looks like to work up and evaluate somebody for dementia. So this is a person who maybe they themselves or a loved one or another provider or someone in their life has concern about dementia. And this is kind of all that goes into what we as providers do to evaluate somebody for a dementia diagnosis or a mild cognitive impairment diagnosis. And this is what we call in our clinic the memory assessment or a memory eval. But this can be called many things depending on where you're getting care. And it includes careful attention to a lot of different parts of a patient's health and life. So we do a long, thorough history on the memory problems that they're noticing, when they started, what specifically that entails. And really, I think the history is one of the most important parts because we look at medications, we look at their living situation, we look at their other health, substance use. All of that is kind of the Q&A that a provider will do, or that a multidisciplinary team will do with a patient and their family. We do a physical exam, a neurologic exam to make sure there's nothing else causing the memory changes. We do a functional assessment. This again could be a whole topic in and of itself, but when I say functional assessment, we talk about activities of daily living, and there is a specific list of things that we look at, and that is really your ability to take care of your own needs, your day-to-day functioning in terms of like your ability to survive. That's going to the bathroom, feeding yourself, walking, getting dressed. And then we look at what we call instrumental activities of daily living. And that includes things like using a telephone, paying your bills, managing your medications, going shopping, cleaning. And these are all things that one's ability to do independently can change over time. So as geriatricians and primary care providers for older adults, we pay special attention to this because it can sometimes be a clue or insight into somebody's cognitive changes. Depression screen, again, we'll talk about this a lot more, but this is a big part of a dementia diagnosis because depression can mimic dementia. And we want to make sure that if we're giving a diagnosis of dementia, we're ruling out other things. And we rule out other conditions, some of which I've mentioned already, with labs and imaging. So we'll look for thyroid disease, vitamin deficiencies on lab work, make sure there's no other cause like an infection that's causing someone to be confused or having problems with memory. Imaging is not always a part of a dementia diagnosis, but some providers, and depending on the history and the concerns, will get brain imaging like a CAT scan or an MRI. Part of our assessment is also talking with caregivers and evaluating their needs, whether a patient needs additional assistance in the home. Like I said, medications are a huge part of this. We also pay attention to driving accidents, driving safety. And then there's a formal memory exam or exams that we do that can range from 10 to 30 minutes, depending on what we're doing and the patient's abilities. And then for somebody with a diagnosis that's maybe a little bit more unclear or murky, we may refer someone to neuropsychological testing, which is specialized testing that is longer, tends to be 3 hours at a minimum. And that's through usually a neurology department or psychology department. This is a great question. Could depression be a result of dementia? Yes. Yes is the short answer. We'll talk about this a little bit more at the end too, but certainly those with dementia are at risk for developing depression, and especially with changes in function and dependence on other people, and also just some of the behavioral changes that come with dementia. Yes, there, and I don't have the statistic off the top of my head, but there is a risk of depression with dementia, certainly. And we definitely try to pay attention to that, especially as memory changes and patients advance. It can be harder to discern the depression. And so we definitely rely on family and caregivers for this too. There are certain reversible causes of dementia, and similarly, kind of those who end up in the mild cognitive impairment categories, things that we can change and reassess a patient, months later to see if their memory and thinking has improved. And those are things like depression, medication side effects, excess alcohol or substances, thyroid problems, and vitamin deficiencies. And we see that when we correct these things, memory does improve, which is again why it's so important to look closely at all of these pieces of a person's history and lab work when we're working them up for dementia. I'll spend a bit of time now talking about the subtypes of dementia, of which there are many. And I think sometimes this is most helpful just in patients and families understanding themselves and what to expect. There isn't necessarily a lot that changes in terms of how we would manage, but it is helpful to know maybe what's coming down the pike or what may be part of this diagnosis that somebody has. So Alzheimer's is the most common cause of dementia, but dementia itself is an umbrella term. So I really like this graphic because this is kind of a visual, I'm a very visual person, of what falls under the dementia category. And that is things, so Alzheimer's, vascular dementia, which we'll talk about, Lewy body, frontotemporal, and then there's other types, and many types are honestly mixed, and it's hard to pinpoint one exact cause. Alzheimer's accounts for about 60 to 80% of cases. So if somebody is told they have dementia or they may have dementia, usually Alzheimer's is what we're talking about. I think previously we thought of that as a smaller subgroup, but it's actually kind of the main feature that we see. So a little bit of information about Alzheimer's, and for all the subtypes, I have text if you're a visual kind of text person, and then I've got some images too. So hopefully there's a little bit of something for everyone here. But in terms of Alzheimer's disease, we do see that this is often gradual onset, and the cognitive symptoms that usually accompany Alzheimer's are difficulty learning new things, learning new information. We call that amnestic. So forgetting new things, forgetting new information, can have difficulty with language, and then visuospatial. So those are things we often see, like getting lost or wandering, or kind of more in the advanced stage. There are rarely motor symptoms in the early form of Alzheimer's. At what we would call end stage Alzheimer's, like when someone is very close to the end of life, you can have difficulty moving, walking, like remembering how to walk well, and kind of the coordination of the body gets lost, but that is very rare early on. This is a very gradual, slow progression. We see slow changes. It often happens over 8 to 10 years on average. Often lab tests are normal and imaging tests tend to be normal. Sometimes on a brain scan that can get read as what we see as like global atrophy or like decrease in brain tissue size. But that itself does not diagnose Alzheimer's. And this is something that affects almost half of people over the age of 85. So again, it is associated with age, but there are many, many older adults who never develop Alzheimer's disease, so not inevitable. Kind of a visual, and again, some of these percentages I think have changed over time, but this causes death of the neurons, difficulty with memory, recall, and mental abilities. And it's attributed to many, many factors. It's hard to pinpoint one cause. And we'll talk about treatment more kind of after this section, but being proactive about health and routine is very important for Alzheimer's. There is a very, very small portion of people who develop Alzheimer's at an early age. I'm not going to talk about that more unless people have questions, but that's also kind of separate from today. I think this is helpful. We as providers look at the FAST criteria for staging Alzheimer's, and it's a bit, that piece of it is a little bit irrelevant, but I think just looking at the different kind of changes that you might expect to see over time, some of these are a little bit more drastic, but if you look at the time frame, like Someone who's having possible Alzheimer's disease is that stage 3 could last for 7 years. So this is a very slow, prolonged changes. Things like having difficulty with finances, and with mild disease, someone may have that for 2+ years. So these things evolve quite slowly. It's not necessarily a drastic change. The next kind of subtype is vascular dementia. And this refers to vascular damage in the brain, usually relating to severe heart disease or stroke. But in somebody who has a history of those illnesses and then begins to develop memory issues, they may end up with a diagnosis of vascular dementia. And the trajectory of vascular dementia is a little bit different from Alzheimer's in that it's not this same slow progressive decline, but sometimes you see a sudden or stepwise change. So if somebody who has a history of a stroke, they may have this, they may be functioning at a certain level after a stroke, and then there's this kind of abrupt going down a notch in terms of what they're able to do. This often depends on the anatomy of the area of the brain that's affected by the stroke, but can often cause changes in your executive functioning, so ability to plan and do complex tasks and kind of judgment, and also kind of slowing mentally and physically. And again, you may have motor symptoms if you have motor symptoms from stroke, but not everyone with vascular dementia has motor symptoms. And the progression is also, it can continue to be stepwise if there are continued events that are related to someone's neurovascular or cardiovascular health, but it could also be gradual. Often patients with vascular dementia have a mixed picture. So this one is one of the ones that's hard to parse out. Often lab tests are normal. You may have changes on MRI that are seen, but you may not. And again, this can be really challenging to separate from Alzheimer's at times. So I think this is there's a big Venn diagram in terms of overlap with Alzheimer's. And just kind of put differently, I would pay less attention to the average life expectancy, because I think we really don't use those to guide our care and our management, and every person is different. But for people who have had strokes or some sort of ischemic vascular disease in their brain, it becomes very hard to think clearly and think independently. Risk factors, things like head injuries, high blood pressure, diabetes, smoking, are all things that can over time cause brain damage. And so again, I think for the purpose of this talk, focusing on preventive health and avoiding those things is really key here. The last two subtypes of dementia we'll talk about are less common, but I think are helpful just to know about because they have kind of characteristic features. So Lewy body dementia comes often with hallucinations, or what we call Parkinsonian signs. So there are certain characteristic slowing of movements that we see with Parkinson's, but we see often these motor symptoms coming on at the same time as memory changes. So for somebody who has, and I'm not going to talk a lot about Parkinson's, but for someone who has Parkinson's, often we see motor symptoms well before memory changes. People can live and think clearly and normally with Parkinson's for some time. And not everyone with Parkinson's ends up with dementia. But for somebody who's presenting with cognitive changes and these characteristic hallucinations or Parkinson-like physical features, often those folks end up with a Lewy body dementia diagnosis. It does come on gradually and it does progress gradually, but it tends to have a faster progression than Alzheimer's disease. And again, you're not going to see much on lab tests, and imaging may show this global atrophy or like overall shrinking of brain tissue. Often also these folks, the fluctuating symptoms, that really refers to attention. So whereas somebody with Alzheimer's may be able to carry on a conversation and focus and attune to another person who's with them, people with Lewy body can have really different kind of a scattered attention and alertness. This can also come with sleep problems, and can often be misread or misunderstood as a psychiatric diagnosis. And then just some more kind of visual information. So this is characterized by an accumulation of Lewy bodies. So it is like physiologically distinct. It can start earlier on, but again, really common features of this that are not as common in Alzheimer's or vascular dementia are visual hallucinations, very unusual sleep behaviors, and problems with movement. Has a shorter life expectancy overall. Again, I pay less attention to the years, but just in terms of how we see folks progress, they can decline a bit more rapidly than those with Alzheimer's disease. And then frontotemporal dementia is also very unique and can occur in folks who are younger. We see a lot of difficulty with executive function, disinhibition. So people who are impulsive or have extreme lack of social awareness. And again, this can happen in somebody with late stage Alzheimer's or vascular dementia, but we see this early on with frontotemporal dementia. There are some subtypes of frontotemporal dementia, and it can get pretty nuanced, but you can have a lot of trouble with speech and language in frontotemporal dementia as well. Usually this is not seen with motor symptoms and can progress more quickly. Again, you'll see normal lab tests in a workup for a patient with frontotemporal dementia, and you may see specific brain tissue loss in the frontal and temporal areas, which are the areas of the brain that are affected. Often I have plus minus memory on here because often memory changes are not as pronounced in these patients, especially in the early stage of frontotemporal dementia. Again, this is like people really acting out of the norm for their personality. We see family members who are like, this is just not how this person has been, or would not, this is not like anything they would ever do. And the kind of frontal lobe of our brain helps with like judgment, decision-making, planning. And so having that area be affected really shows up in this type of dementia. Just to summarize and kind of like boil down the dementia subtypes, again, Alzheimer's disease is going to be the main type of dementia that we see. And this is with memory, language, and again, visual spatial skills. So knowing your way around and kind of navigating through the day-to-day. Vascular dementia is probably the second most common, and you often see this co-occur in patients who have stroke or other vascular risk factors. And that can affect motor skills and judgment, mainly because of how strokes affect individuals. And then frontotemporal and Lewy body, very, very specific in terms of how their symptoms show up. There are mixed types and other types that are very, very much more rare or unusual. So I'm not going to spend too much time on those. I've spoken about this a bit, but just to give it its own spotlight, depression in older adults mimics the same kind of memory changes that show up in dementia. So problems with recall, pulling up those words, recalling a conversation, knowing when an appointment is, those things that we see early on in Alzheimer's that are commonly affecting someone's day-to-day life also show up with depression. If you've noticed that if you've ever experienced that, you may also notice being in a fog, being forgetful, having a really hard time concentrating. And for people who end up with a diagnosis of depression, which we see often in our memory workups in my clinic, when we treat their depression and we reevaluate their cognitive skills and their memory, oftentimes they do improve. And certainly untreated depression can be a risk factor for developing dementia. So even more of a reason and like impetus for us to pay close attention to this and treat this. So I see the question about hand. And again, I refer to this, I think it's like briefly in the last slide, but yes, we can see in like really advanced HIV and HIV acquired neurological disorder, I think there is some dementia and some overlap with dementia. And I think probably under the umbrella or maybe aside on its own, you could have that. I don't know too much about hand, and I, to be honest, have not seen a patient with that. So I'm curious to learn more. But yes, I'm sure there are many overlaps. I think dementia is this like very broad, like I said, umbrella term that encapsulates a lot of things. I want to focus a little bit on the treatment of dementia. I'm not going to talk about some of the medications you may have been seeing in the news more recently that are newer, like aducanumab and lecanemab, which are monoclonal antibodies that specifically target the plaques in Alzheimer's disease, because they're really new and their use is very, very limited. Though there is a lot to be said about those. What I will focus on, I think, are the things that we as providers try to promote most strongly and are things that we see the greatest impact in a patient's day-to-day life. So I think, the unfortunate piece of this is that there isn't a cure for dementia. There is not a quick fix, and even the medications that have been on the market for longer have limited use, and I will talk about those. But I think there is a lot in the way of patient and caregiver and family education and support that can really help optimize somebody's day-to-day life and functioning who has a diagnosis of dementia. So again, the overall goal for us, for patients and for families, is to improve quality of life and maximize functional performance. So by that, we mean independence in those activities of daily living I was speaking about. And that what we can do is focus on their thinking, their mood, and their behavior. And there's kind of different strategies that we can teach families and patients about in order to optimize this. So the bulk of treatment, I would say, and the best kinds of treatment, because they have the fewest downsides, are the non-pharmacologic treatments. And again, a lot of the treatments for dementia are also things that can help prevent developing dementia. But having a healthy lifestyle, a balanced diet, good sleep, and physical activity is paramount in treating dementia, often because it can help prevent further decline and further complications. So things like maintaining a normal blood pressure, cholesterol levels, healthy glucose levels in patients who have diabetes, stopping smoking or limiting alcohol use. These are all things that we know can progress dementia. Having a Mediterranean or a DASH diet, like I mentioned earlier, has shown, there's evidence to show that that can help kind of maintain patients with dementia. And we see folks who have really poor kind of lifestyle habits or addiction or substance use, they can fare far worse. Maintaining a healthy weight, having social interaction is also key. We know there's, especially with the pandemic, so much social isolation. especially for older adults, and just having interaction, keeping the brain on and being used, and having intellectual stimulation, being in community, is huge for patients. It reduces stress, it improves mood, it makes thinking clearer. And then family and caregiver education and support, like I said, a huge part of our work, and the Alzheimer's Association also, is family provide support, because caregiver burnout is so huge, and being like employed with tools and skills to support a loved one can help a caregiver and help a patient so much. One of the big things we talk about is safety. So again, trying to maximize someone's functional status and maintain their safety is probably something I say a lot to patients, but focusing in on driving and knowing when patients are okay to drive. But if they're having accidents or wandering or getting lost or have trouble remembering where they are, knowing when they need supervision and just being aware and vigilant about this is key. And then there are day-to-day modifications that can be made, things like having clocks in many rooms to reorient patients or individuals, heavy use of calendars, using a to-do list, visual clues, structured activities. There's a lot of research to suggest these helpful reorientation cues for patients. Couple disclaimers about the medications. The main treatments that are used right now in terms of medications are cholinesterase inhibitors and memantine, which I'll talk about how they work on the next slide. But those have been studied fairly well, and they show marginal clinical improvement. Sometimes some of the studies show that you may do 1 or 2 points better on a memory assessment, but that's not like showing significant changes in function or in overall day-to-day life. The studies have showed repeatedly limited efficacy, and there's certainly no FDA approval or recommended use for somebody who only has a diagnosis of mild cognitive impairment. It's not like if you have that diagnosis, taking medications is shown to prevent dementia. It's not. These also come with significant side effect profiles. This is kind of the recommendation that you see a lot in the evidence in the literature, and that we often hold by, but it's not by any means set in stone. So for a patient who's on these medications, we like to reevaluate them in 6 to 12 months, especially for somebody who's having side effects. Often the harms outweigh the benefits of the medications. But if you're not seeing any significant effect in terms of memory and thinking after a year or half a year of use, it's recommended to stop those medications. There is some report of patients kind of declining after stopping those medications. And in that case, certainly you could restart those medications. But oftentimes, these patients have a lot of medications that they're already on. And this is one more that we know is not showing us any significant effects. And so it can help reduce their pill burden. This is also not recommended for vascular dementia. These are really recommended for Alzheimer's dementia, and for those with Lewy body dementia, sometimes you can have improvement in like the attention and behavioral symptoms. Just in terms of the medications specifically, so the cholinesterase inhibitors these are some of the names of them. So donepezil is the generic name, and the Aricept is the brand name. You may have heard of that one. Rivastigmine or Exelon. These are used in any mild to severe dementia, and they slow the breakdown of acetylcholinesterase in the brain. But again, come with significant side effects like GI upset, which includes nausea, vomiting, diarrhea, can lead to weight loss and abnormal dreams. And again, for patients who are having a heavy side effect burden or more side effects than positive effects, we often stop these medications. And then memantine is an NMDA receptor antagonist, and that is only recommended to be used in moderate to advanced dementia and also comes with side effects, so constipation, dizziness, and headaches. Especially in Alzheimer's dementia, symptoms can progress and become more behavioral and more bothersome, both to patients, but especially to families and caregivers as things go on. So huge ranges are cited, but many patients with Alzheimer's dementia can have delusions, hallucinations, like I mentioned, wandering. Often we see agitation, so being upset, occasionally aggressive. This is something that again can happen late in the later stages of dementia, and we call them the behavioral kind of symptoms of dementia. And these are often indicative of other underlying processes that maybe a patient is not able to articulate, but emotional distress, pain, delirium, or physical discomfort. And the recommendation is to treat these supportively. I'm not going to spend today talking about antipsychotics. They sometimes can be used in situations where patients are really kind of a risk of harm to themselves or somebody else, but often these behavioral issues are what make caring for people with dementia so difficult and often lead to a heavier reliance on hired care or nursing home care. And I just wanted to kind of mention them as kind of to represent the full picture of what dementia can entail. In Philadelphia and in most cities, counties, there are a lot of resources, especially in Philadelphia, but often leaning on a geriatrician, a geriatric psychiatrist, or a neurologist. And like if somebody, like I said, is getting neuropsych testing, going to a neuropsychologist can be very helpful because these are people who are experts in dementia and other geriatric syndromes. But going to an office also that has interdisciplinary team use, so relying on social workers to help coordinate services in the home for a patient. Physical therapy and exercise therapy is huge for patients. And we have a geriatric pharmacist in our office who goes through whole medication lists and kind of clarifies and cuts fat for patients in terms of medications that cause more harm than good or aren't providing benefit. Leaning on community, so especially to prevent caregiver burnout, but home health agencies, neighbors, mental health networks, there's adult daycares, there's respite care, and then the Alzheimer's Association and PCA are huge resources here that we lean on heavily. And services, like I said, something that a social worker could help set up for a patient maybe who lives alone and is struggling to get meals for themselves. So there is a lot we can offer patients aside from the physician and their family in terms of support. So some of the takeaways I think that I hope you all gleaned from this are that dementia is common in older adults and becomes more common the older you get, but is not an inherent or inevitable part of aging. For somebody who has concerns or who has an abnormal screening or is showing signs, they should go get a formal workup. And that includes a history, looking at their functional status, a cognitive assessment, depression screen, labs, and imaging. So it is very comprehensive. In terms of subtypes, Alzheimer's disease is the most common type, followed by vascular dementia and Lewy body dementia. And then treatment really focuses on quality of life, thinking, mood, behavior, and having healthy habits, so physical and brain activity. And that medications can show some modestly slow cognitive decline, but we're not leaning as heavily on those right now. I will stop my sharing and see if there are questions in the chat.
Doctor, I do see some in the Q&A.
Yes, so if Alzheimer's or dementia occurs in a parent, is this genetic? What is the risk for this being generational in the family? I would say there is some risk. We do ask about family history. It's something we consider. That's kind of one piece in the full picture. So I think the answer to that is not clear cut. Having a family member who has dementia certainly increases your risk of having dementia, but it doesn't necessarily guarantee that you will have it. Genetics are kind of funky that way. But yes, so there certainly is some genetic link that we see. And I really need to look into hand more. I don't know if this person wants to say more about that, but I'm happy to answer any other questions. Hope this was helpful. There's kind of a lot that's known about the dementia types and less and less about treatment and prevention. So I think that can be kind of dissatisfying in some ways, but hopefully knowledge is power, and knowing more helps ask the right questions, advocate, look for signs either in yourself or family members or loved ones, and just bring awareness to this that I think is often very stigmatized and overlooked.
Yeah. Doctor, could you give us your contact information?
Oh yeah, sure. I will put my email in the chat.
That would be great. This has been really, really informative.
And we're the Center for Healthy Aging at Jefferson. Our office is all geriatricians, and we do primary care, and we also do like specific one-off memory assessments if somebody is
Here.
concerned. And there's really no kind of like wrong patient for a memory evaluation. If a patient or a family member has significant concerns, we're happy to do a workup in our
Uh,
office.
This is Jimmy. Can you hear me, Dr. Flink?
Yeah,
Just a quick question. Would neuropathy be a precursor to any forms of dementia?
that's a great question. Not that I know of.
Okay.
Neuropathy is often unexplained, but is sort of like more in terms of like sensation and pain pathways than, I don't know if there's any correlation with like neuropathy and changes in like your brain neurons. I don't think so.
Okay. All
I
right.
think to me those entities are separate, but I can look for a more.
And in conjunction with the person who asked the hand question, I'm very interested in finding out about that. I just learned about it maybe 6 months ago, and I don't really understand it. I presume it's that like HIV crosses the blood-brain barrier and causes neurological issues in your brain. But I'd be really fascinated by that if so at some later time you came on and discussed that.
Yeah. So I don't think the participants can see the chat. So if
Oh,
anybody needs
sorry.
Dr. Flink's information, just give us a call or email us at the same email address you have
Here we go.
for our programs, and we'll give you her contact information.
I really want to learn more about hand, but from a quick just search I did, it talks about how much of an impact heart treatment and aggressive treatment of HIV reduces dementia risk.
Huh.
So reduces dementia risk related to HIV. So that's very optimistic, I would say.
Yeah.
And that patients who have signs of dementia, who are on therapy, who are on heart treatment, show some improvement in their like neuropsychological deficits. So I think what they're trying to say, and again, I have much to learn on this, is that you can have There's actually, let me throw this link in because there's a whole page on hand from the Alzheimer's Association.
Well, when you do learn about it, please come back. We'd love to hear from you.
Here's this link, which you can,
Thank you.
that should have gone out to everyone. Now I think I fixed my chat. But honestly, I use the Alzheimer's Association websites often. They're super helpful, and really informative and easy to read. So, I recommend looking at these sites.
That's great. Thank you for doing that.
Other questions? Oh, it looks like there's one more. Oh, yeah, you're welcome. Thank you all for coming and for your questions.
Yes.
I hope this was helpful.
Thank you, Dr. Flink.
All right.
Yeah, it's been great. Well, listen, I want to thank everybody for participating. And of course, Dr. Flink, it was exceptional. I learned a lot.